Great. Welcome, everyone. I see a lot of folks are tuning in to join our webinar today, Lessons Learned. We will be getting started at the top of the hour. Thank you so much for being with us. This webinar is being live streamed on PWN's Facebook page, Positive Women's Network USA. Feel free to go there and share it to your own Facebook page if you'd like to amplify this as well. Awesome. Thank you, Kelly, for the link. Can I get the slides up, shared?
Yep.
Thank you. Great. Welcome, everyone. Thank you so much for joining us today for our live streamed event, Lessons Learned, Engaging Community in the Use of Molecular HIV Surveillance Data. I'm Naina, Khanna, pronouns she or they. I'm the co-executive director of Positive Women's Network USA. I'm also with the US People Living with HIV Caucus. And for those who don't know Positive Women's Network, or PWN, we are a national membership body led by and for women and trans folks living with HIV. We exist to build power in communities most impacted by the epidemic in the United States. So that's Black, Brown, Indigenous, people of color communities, queer and trans folks, low-income folks, people who are often historically left out of decision-making processes, who live at the intersection of multiple different forms of state and structural violence. We exist to build power in those communities. We view HIV not as the problem, but as a symptom of many different broken systems that come together to create inequities for our communities. And so that's the lens that we bring to our work. We're so proud today to be bringing you a panel of really fabulous researchers and authors of a very important paper that came out recently about lessons in research ethics, really, and how to engage community responsibly in research processes. I want to thank the researchers who are going to be with us today so much today for making the time. Today we have Doctors Alic and Josh Herbeck, Brian Minalga, and Diana Tordoff joining us for this panel. Thank you also to our audience. Thank you so much for being here. And I also want to shout out the PWN policy and communications teams for helping to make this happen today, really helping us get the word out about this important paper and also this event. Let's go to the next slide, please. So in today's conversation, we are going to first hear from the featured authors here of the paper. They're going to introduce themselves, and then we're going to hear an overview of the paper itself for those who haven't had the chance to read it. We'll give a little overview of the paper. Diana Tordoff will be presenting that to us. And then we're going to have a conversation with the authors about why this paper came to be, how it came to be. We're going to have some time for question and answer with all of you. And then we're going to close out. There are a couple ways to ask questions. So there is at the bottom of your Zoom link, at the bottom of your Zoom window, you should see something called Q&A. You are welcome to type questions in there anytime. during the webinar, and we will do our best to respond to them either in real time or later during the facilitated discussion. You can also raise your hand if you want to verbally ask a question. I think we'll be able to unmute you during the actual Q&A part of the conversation. And then also to know, this webinar is being live streamed. You can find the link. I don't know how to share it actually with everybody. But if you go to Positive Women's Network USA's Facebook page, you can find the live stream there. Go ahead and share it with your own communities, help get the word out, and also tweet with us. We're live tweeting this event at USPWN using the hashtags research responsibly and hashtag end MHS. So again, thank you all so much for being here with us today. And I'm going to go ahead and ask our panelists to introduce themselves, first of all, names, pronouns, and the role you had on this research project and the paper. Maybe why don't we go ahead and start with Diana?
Thanks, Nana. Hi, everyone. My name is Diana Tordoff. I use she, her pronouns, and I'm a PhD candidate at the University of Washington. For this project, I was the lead author on the preprint we're talking about today, and I was also the lead author and data analyst on the original study we chose not to publish. While working on this project, I was working under the mentorship of Joshua Herbeck, who is going to be joining us later today in the panel.
Great. Alic, would you like to go next?
Sure. Hi, everyone. I'm Alic Shook. I use the pronouns he, him. I am an assistant professor in the College of Nursing at Seattle University. I work on a number of qualitative research projects, and I was the qualitative researcher who conducted an analysis based on interviews with folks in the community and providers in Seattle around community perspectives on MHS and MHS-guided interventions.
Great. And Brian.
Hi, everybody. Thanks so much, Nana, and to PWN for hosting this live stream. My name is Brian Minalga. I use any pronouns, and I work at the Fred Hutch Cancer Center in Seattle. I came into this paper through my work in biomedical and behavioral interventions throughout the NIH-funded HIV/AIDS clinical trials networks is my primary role. And so at the time, I was looking at ethical considerations for using phylogenetic analysis of HIV in our clinical trials, and then came to understand that this research was happening as well, the original paper that we'll be talking a little bit about today. So I come into this role sort of as a liaison, I would say, as someone who had been working in this field and was aware of concerns, both on the research side as well as within communities. So kind of acted as a liaison between the original research team and communities, especially networks of people living with HIV, to try to bring these two groups together, and ultimately was invited to co-author the paper we'll be discussing today, the lessons learned paper, with the original research team.
Great. Thank you so much, Brian. And we will have one final panelist joining us a little bit later in the webinar, and we'll have them introduce themselves when they join. And again, I'm Naina, Khanna, she or they pronouns. I'll be moderating today's conversation. I come to this work as a woman living with HIV and as a member of multiple networks of people living with HIV. Networks of people living with HIV are basically organized formations that are accountable to the constituencies that we represent. And as Brian kind of alluded to, networks of people living with HIV have been raising concerns about molecular HIV surveillance and the use of genomic sequencing for a number of years. And so we're really grateful to be in conversation with these authors today and have the opportunity to engage in a conversation about what it looks like to really be responding to concerns that are coming from directly impacted communities. So with that, I'm going to go ahead and turn it over to Diana to walk us through an overview of this incredible paper.
Thank you so much. So today we're here to talk about our recent preprint on community engagement around the use of molecular HIV surveillance data in research. Next slide, please. So our preprint describes our processes as well as some of the key things we learned from our community engagement processes, namely the lack of informed consent, directionality, that is being able to identify instances of direct transmission, criminalization, stigma, and structural racism. But before we begin our conversation, I'll just briefly touch on our processes. Next slide, please. Specifically what our original study was and then why we decided not to publish it. Next slide. So the motivation of our study was to address HIV-related disparities among MSM by age, race, and ethnicity. And in particular, we are interested in assortativity, which is the increased likelihood of choosing partners from one's own identified subgroup. Particularly because assortativity has been hypothesized to explain racial disparities among MSM. So our original study aimed to use MHS data to describe transmission patterns by age, race, and ethnicity. Next slide. Oh, I forgot about that. Yeah, next slide, please. So to do this, we used HIV sequences from over 3,000 men who have sex with men in King County, Washington. And we used a new phylodynamic modeling approach to estimate a transmission probability weight, or a number between 0 and 1, for all pairs of HIV sequences in the phylogenetic tree we reconstructed from these HIV sequences. We then aggregated these probabilities and looked at population level patterns. Next. One more. I'm sorry, I forgot about these animations. So for example, we were able to make inferences like Black men had an X% probability of acquiring HIV from another Black man, or we were able to make statements like Hispanic men were Y% more likely to acquire HIV from a man of the same ethnicity compared to what would have been expected under random transmission. Next slide. Can you just click through all of the animations? That's good, thank you. So after conducting community engagement, we decided not to publish our study. And in making this decision, we asked ourselves 3 key questions. And we really hope that this framework is useful for other researchers. So given that the HIV sequences we used in this research were collected through MHS and were obtained without informed consent for their future use in research, we felt this raised important questions. First, does this research translate into public health action and efforts to end the HIV epidemic? Second, does this research benefit, or at minimum not harm, communities of people living with HIV who are included in this research without their consent? And third, does this research equitably distribute the benefits and risks both to people living with HIV and people susceptible to acquiring HIV? Next slide, please. So ultimately, we thought that publishing our findings would perpetuate racialized stigma about and among MSM, and also erode trust between phylogenetics researchers and communities of people living with HIV by choosing to publish our study despite their clear and consistent concerns about our original study and its findings. Next slide. So while we do believe that HIV phylogenetics is a powerful and potentially useful scientific tool, there are significant concerns rooted in consent, criminalization, and stigma. And we believe that communities should be empowered to set the priorities for how, why, and when we do these types of analyses. Last slide, please. So my big takeaway from this is that I believe that researchers are well positioned to help facilitate increased dialogue about MHS that meaningfully includes people living with HIV, and also to conduct research that examines these issues. So in our preprint, we've included a number of recommendations for how researchers can advocate for structural interventions, promote autonomy and transparency, and also bridge understanding and develop partnerships between community members, researchers, and public health practitioners. So thank you so much for letting me give that brief overview, and I'll pass it back to Naina.
Thank you so much. And there's so much in this paper. We really want to encourage folks to read it. We will make sure that everybody who is registered for this webinar gets the link. And I see that Kelly has also dropped it into the chat here for everybody. We encourage you to go ahead, download it and read it at your convenience. So thanks, Diana, for that powerful overview and for this really powerful work. It's a pretty big deal for researchers to take a pause and really listen to and consider community concerns, after a project is underway. And I think that it really shows a level of rigor and attentiveness and commitment to the principles that you so clearly articulated are guiding the work. So let's back up for a second. Can you all share with us today, why is HIV sequence data used in research in the first place?
I'm happy to take this. And I thought this question might come before Josh was able to join us. So I also have a few of his points because he's an evolutionary biologist. So HIV sequence data provides unique information about HIV strains, including information about drug resistance genes. So this information is useful for vaccine development, understanding PrEP efficacy, for example, by monitoring for tenofovir resistant strains, and also for providing and developing appropriate HIV treatments. So it also provides important information on how viruses evolve over time and space. So for example, phylogenetic analyses have helped us determine the historical origins of HIV, including estimating when it was first introduced into human populations. So it isn't just HIV as a pathogen in which sequences are used. Gene sequences are used to study almost every pathogen, but HIV is a special case of genomic epidemiology because it evolves so quickly, which causes drug resistance and other problems for vaccine development. And also compared to other pathogens, there exist very large data sets of HIV sequences. And because of this, HIV genomic epidemiology has been the cutting edge for development of methods in general that are now used in other pathogens like influenza, SARS-CoV-2, and even monkeypox.
Yeah, I kind of want to chime in there too, because I kind of referenced how I had been looking at this from a research perspective, clinical trials. So what we're mostly talking about today is the public health arena and how molecular HIV surveillance is happening through clinical care for people living with HIV. But HIV phylogenetic sequencing has been performed in HIV clinical research for a long time. For example, we have a whole suite of studies called partner studies, whereby couples were enrolled into a clinical trial. So these are couples whereby one partner is living with HIV and the other partner is not living with HIV. And so examples of these studies are HPTN 052, Partner 1, Partner 2, and the Opposites Attract study. And what these studies all contributed to was something that probably most people here are familiar with, which is U equals U, the finding that under conditions of viral suppression, a person living with HIV cannot transmit HIV sexually to a partner. And the way that we were able to come to this conclusion was through these partner studies. And phylogenetic analysis was used in these studies to determine, so for example, when HIV transmission occurred, so the HIV originally negative partners in the study tested positive in the context of the study. They used phylogenetic analysis to determine that the HIV did not come from that person's original partner, which indicates that the partner was not the one who transmitted HIV, thereby U equals U. HIV came from a different source. So I just wanted to contextualize that as well, because there is this pretty big difference between the use of phylogenetic analysis in the context of HIV clinical research, where a very meaningful finding, an applicable finding, came out of that suite of studies. Now there's this global campaign called U equals U that was only possible because of these studies that used this type of analysis, phylogenetics. It's very different from what we're talking about today, which is the public health use of HIV sequence data derived from doctor's appointments, whereby people living with HIV are not consenting to this type of use of their data the way that informed consent is performed and required in the context of clinical trials.
Yeah, thank you so much. I think that's such an important distinction. And, really a lot of the community concerns about molecular HIV surveillance arose in the context of PS 18-1802 and the large expansion into the public health arena. And basically the requirement, that this kind of genomic sequencing was utilized as a part of surveillance. So, y'all have alluded to, concerns that have been raised about this kind of data. So what are some of the concerns that have been raised and who has been raising them?
Alic, do you want to take that first?
Yeah, sure. I'll jump in. So kind of backing up a little bit, prior to this particular study that we're talking about, I was asked to work on a qualitative study and do interviews with folks in the community in Seattle and public health, Seattle, King County, so broader Seattle, around people's knowledge of MHS, as well as concerns people would have about MHS guiding public health interventions. So we interviewed folks both living with HIV and folks at risk for HIV through a low barrier clinic that's here in Seattle, as well as providers. And there's a number of things that came out, big concerns around the context that MHS data is being used. So a lot of the people I talked to through interviews were concerned about the usage of MHS data, like exacerbating existing medical mistrust. And for a lot of the people I talked to, they had existing relationships that were really positive with public health Seattle King County, but were worried about how these data are used at the federal level. A number of folks also talked about experiences they had with other public health departments and were concerned there. There are issues around messaging about MHS. So kind of getting at some of the things that Brian has talked about in terms of consent. How does one meaningfully consent to something when they're provided with information that is either inaccessible or not understandable to them, right? In interviews with people, including providers, I spent a fair amount of time having to explain MHS, what it was, before I could solicit people's reactions to this, right? It's not that people couldn't understand it. It was a matter of how this information was provided to people, which tended to be a very lengthy conversation that involved a lot of question and answer. And then we've sort of alluded to this already, but I'd like to make two other points. Some of the biggest concerns were around how confidentiality is operationalized in terms of tight-knit, either sexual networks, sexual networks, or networks of folks who are using and sharing drugs together. When we're talking about directionality, there was a big concern around what does confidentiality look like? How do we interrogate how contact is made with folks who may be at risk and part of a network where HIV is present and phylogenetic analyses are being used to deploy resources and notify folks that maybe they need testing or referral to various services. And then the last thing, which was significant and showed up in most of the interviews, was concern around stigma and power and vulnerability. And specifically, many of the community members were worried that cluster investigations using MHS data are likely to reinscribe assumptions about communities that are disproportionately affected by HIV, and that some of these public health actions and the lack of transparency about how these data are being used could exacerbate existing HIV-related stigma that not only will impact individual people living with HIV, but also is likely to impact folks' willingness to access particular services related to HIV. Diana or Brian, I imagine you might have other things to add if you want to jump in as well.
Yeah, just to kind of, I've been thinking about where this all began for me. And, I had mentioned already that we were thinking about this in the context of research and what protections we needed in place when doing phylogenetic analysis and clinical trials. But it was in 2018 when I attended the HIV is Not a Crime Training Academy at Purdue University in Indianapolis. And right before the conference, I want to say it was like the day before, an email went around to certain folks who were going to be at that conference. And this conference, by the way, is all about HIV criminalization and advocacy around how to change laws and avoid the criminalization of people living with HIV at the state level. And so this email went around about a new requirement. This was in 2018. Which was the year that the CDC began requiring health departments to engage in cluster detection and response activities using molecular HIV surveillance data. And so this email went around with a concern about the potential for these data to be used in HIV criminal cases. And a couple people were invited. So I was one of those folks who was invited, and there was like a classroom that they had booked at Purdue where a few of us were going to come together and just kind of talk about what we knew. So I showed up to that room, to that classroom, expecting to see like, 4 or 5 people there. And the entire classroom was full of people who had heard, secondhand about this new technology that was being used, whereby their sequences, people living with HIV, their sequences of their HIV were being used in this way, that they had not been informed about it. And, in the context of criminalization, the whole reason we were at this conference, there are, criminalization is a current practice, an ongoing practice whereby HIV status, HIV positive status is criminalized. So people are being incarcerated, otherwise, interrogated for simply having HIV. And I'm very intentional about using that language because the majority of these cases are not actually criminalizing HIV transmission. There's typically no transmission within these cases. What usually happens is someone is accusing a person living with HIV of not disclosing their HIV status. So we're not even talking about some type of, imminent public health threat. We're talking about stigma. We're talking about discrimination against people living with HIV. And we're also talking about a very broad and deep context in US culture of overall criminalization of communities of color, Black, Indigenous, brown people, queer people, trans people, sex workers. And so this was already the context before molecular HIV surveillance. So now we're at this conference and people begin hearing that their sequences are being put together in these databases whereby, is it possible to determine who transmitted HIV to whom? This was a question that was raised at this meeting. How are they getting the sequences without telling us that they're using the sequences in this way? There were concerns raised about, as Alic mentioned, doctor-patient confidentiality, about privacy. And then, to tie it back to our conversation today, how then are researchers, so not even, providers working with people living with HIV, but researchers, academics who are in universities and places like where I work at Fred Hutch in Seattle, how are researchers able to access these sequences and then create mathematical models and publish research using these data derived from doctors' appointments where the patient never gave their consent for their data to be used in this way? So just a few of those, that's kind of a mini crash course in some of the concerns raised, highlighting criminalization, consent, bodily autonomy, all issues that are interconnected at this current moment in American society to a lot of broader issues affecting underrepresented populations.
Yeah, thank you so much for highlighting that. And I certainly remember that meeting very vividly. It was a packed room, folks out the door, basically doing, kind of like popular political education style, like, here's what we know, here's what I've read, here's what I've seen. And it was really a moment of the community coming together that I think is very in the lineage of HIV activism. Folks learning the science and educating ourselves. So thank you. I'm curious for as researchers on this project, how did you become aware of these concerns and how did you start to see them applying to your work? What was that process like?
Yeah, that's a great question. So this project was funded originally in 2016, and I joined the research team in the fall of 2018. So around the time that the CDC started mandating the use of MHS sequences. And so I first became aware of these concerns through a webinar series that was hosted by the Legacy Project on HIV phylogenetics. It's wonderful, and I think it's still available online for folks. And so in response to the requirement for health departments to perform cluster detection and response, and then the subsequent inclusion of cluster detection and response as the fourth pillar of the Ending the HIV Epidemic in 2019, there was an increasing number of publications, media, conference presentations across 2019 and 2020 that really described all of these emerging concerns. But until the fall of 2020, I felt that many of these concerns focused on MHS and public health practice, and I just had not extrapolated how these community critiques also applied to our research. I think one of my big blind spots was, well, we don't have identifiable data. We're never shared identifiable data, and so how could this research potentially have the same type of harm as cluster detection and response, where public health departments do have identifiable data. But in September 2020, the American Journal of Bioethics published a series of articles about ethical concerns for HIV phylogenetics research and research. And this article specifically talked about concerns with directionality and criminalization and research. And because of the novel method we were using, which I described earlier, which estimates pairwise transmission probabilities, this was really a critical turning point that made us decide to pause and conduct community engagement.
Thank you. Does anyone want to add anything to that? So, as a team, as a research team, what can you share with us about the process of, receiving critical feedback or starting to engage in this critical conversation and discussing the concerns? Did any tensions surface? And I think, there's also a question in the chat, in the Q&A. Did you receive any pushback on your decision to pause your work? So if you could speak to that a little bit as well. What those dynamics were, internally in this process of really engaging this conversation and these critiques.
Yeah, I mean, it was complicated. Our team on the original study had a really wide range of perspectives and experiences. On the original study, we had some folks with the public health department. And I think a lot of what our process was about bringing folks along on the same learning journey. So we started by first consulting a community engagement office, and we really began by giving a couple of community presentations. And I feel really lucky that Brian attended both of those, and this community engagement process really evolved organically from giving those presentations. We invited folks to review our manuscripts. We had several conversations with folks from the MHS Coalition, which included folks from the Positive Women's Network and many other networks of people living with HIV. And I characterize that period as like deeply uncomfortable and just having a lot of cognitive dissonance. For me as a queer person and as a student, I think it was a particularly like emotional and challenging experience, but I learned so much from it. And I feel really lucky that Josh, who hopefully will be joining soon, was a really like incredible and supportive mentor throughout this whole process. I think there's a question about, here, let me go to that Q&A. So yeah, ultimately there were tensions, and there are several members of the public health department who were authors on our original study, who reviewed our manuscript and gave us really incredible feedback, but did not feel comfortable being included as authors on the lessons learned paper that we have currently shared as a preprint. And so there definitely are tensions, and I think this project definitely embodied a lot of the conflicts that are and differences of opinion between community researchers and public health practitioners.
I'll also jump in as well and say that on the qualitative paper, so keep in mind, this is a completely different study, right? Where the goals of this paper were to talk with folks in the community and with providers in the community, you know, to be specific in Seattle and King County about their perspectives of MHS. Many of the authors are similar, but we had other authors as well. And there was tension among us as authors in writing up the results, right? So the tension showed up there as well. And I would say particularly around issues of criminalization, they showed up, and questions about recommendations for public health departments moving forward. How do we address these issues and community concerns?
Great. Brian, do you want to add anything to that?
I'll hold off for now. I see Josh has just joined us, so I wanted to welcome Josh to the conversation.
Great. Perfect timing. Josh, do you want to introduce yourself, name, pronouns, your role in the research project, and anything else you'd like to briefly share? And then I'm going to actually ask you a question.
Oh, okay. Hello, everybody. I'm sorry I'm late. My name is Josh Herbeck, he, him. I am a research manager at the Institute for Disease Modeling at the Gates Foundation, and I am also an affiliate associate professor at the Department of Global Health at UW in Seattle. My role in this project was well, Roxanne Crony and I were the co-PIs of the original grant funded to do this project. And my role was to help Diana and learn from Diana and the rest of the community about this process.
Great. Thank you so much. And not to just kind of like throw you into the fire right when you show up, but the conversation that we were just in the middle of was kind of, you know, what was it like as a research team becoming aware of these concerns, starting to engage this, the critiques and concerns from the community about molecular HIV surveillance, and also, you know, the types of tensions that may have arisen and emerged. And there is one question also in the Q&A that I wonder if anybody can speak to about what were the dynamics with the NIH and other funders? Was there discussion about how to meet the grant obligations while addressing concerns within the community? So anybody who feels prepared to start speaking to that, and Josh, if you're ready to jump in, we welcome your voice.
Yeah, I can start real briefly. So for me, you know, I was trained in phylogenetics, and Roxanne and I wrote the grant because we believe in using phylogenetics to understand transmission, with the goal of, you know, potentially helping public health offices, you know, provide better prevention mechanisms to communities to end HIV. You know, and so I came into the project believing in the ideas and you know, just doing researcher type things, not really thinking about the community, to be honest. And then we slowly became aware of some concerns and some pushback from the community. Initially, I was not completely open to them because I thought that they were, you know, from my perspective, and you know, in my location in Seattle with our public health department and our academic department, didn't really think the concerns applied to our research. But then, you know, we read more, and Diana and Roxanne and I talked a lot more, and I just became, I saw more of the concerns having real meaning, and I think that while I still believe in the power of phylogenetics and genomic epidemiology as a whole, I do now think that the process in which at least MHS and this type of data collection in the United States is happening needs to be fixed. So with regards to the NIH, I didn't talk to the NIH about this at all. Yeah, they had no role in yeah, they still, as far as I know, don't know that we paused this paper. The grant the grant cycle has ended. You know, we were no longer receiving funding from them just naturally it was a 4-year grant. But yeah, we didn't have to check in with them or anything of that nature.
Great, thank you so much for that. We're getting really fantastic questions in the Q&A part of the chat. So feel free to keep dropping questions in there. Also, if you have a question that is so juicy, you feel like it must be asked live, go ahead and raise your hand and we will try to unmute you at some point. I'm gonna actually switch gears a little bit, and because I think the big thing about molecular HIV surveillance and this type of genomic sequencing is that, as Dazan is lifting up in the Q&A box, it doesn't happen in a vacuum, right? Like, that's the whole point. And this is the reason that communities are raising concerns. As Brian and Alic have really well articulated, concerns about criminalization, about structural racism. As Diana showed us, you know, there are clear sort of racialized aspects to how this data is being looked at, reported, that could have real life consequences for people on the ground. So, you know, the paper specifically references concerns about the context of stigma, structural racism. Can you talk about how stigma and structural racism intersect with the findings from your original paper, and what kind of concerns might be elevated for Black folks, for immigrants, for other communities of color? And then also, you know, just to nuance it a little bit further, because why not? Let's just throw it all in there. We're in a moment where, you know, abortion is being criminalized, where provision of abortion is being criminalized, where bodily autonomy is being criminalized, where an attorney in Texas, who was the architect of SB 8, is also now talking about criminalizing PrEP provision. The Texas Attorney General has also openly stated that he is willing and able to defend a law outlawing same-sex intimacy if it is passed. So these questions about data security, data privacy, the kind of data that's being taken without consent, how it's being utilized, how it's being shared, how it's being deployed, and as activists have really pointed out, and legal analysts and policy analysts have pointed out, the wide variation in data privacy environments, you know, at the public health level from state to state. We're in a moment where a lot of things are unknown about what human rights actually are going to look like. So with this evolution in the landscape that we're dealing with, what does that mean for potential data privacy concerns? And how do you, as researchers, think that should inform considerations moving forward?
Brian, I suspect you probably have something a little more powerful than me to say, but you know, the first thing that comes to mind is transparency, right? I mean, this is a very basic thing. We know that there are privacy considerations. I think people need to be adequately informed about how data and how their biospecimens are being used. And I'm going to veer off. There was a question, one of the first questions in the chat, around like community advocates raising concerns at the state level, and then HIV planning councils, and then just being responded to and saying like, well, the CDC requires that, you know, MHS be employed. I think one of the things that local jurisdictions have a lot of power to do is connect with communities and engage communities around what is the type of messaging that communities want around exactly what is happening with their data and with their biospecimens, right? There is very little guidance from the federal level about how MHS data and MHS intervention should be employed. So I think there potentially local jurisdictions, local communities can hold a lot of power in that regard.
Yeah, I kind of just wanted to like combine a little bit of the last question on the process undertaken, this community engagement process, with everything that you, Naina, have raised, and Dazan in the chat, in the Q&A. So my background is in social work. I focus on macro social work, and I see my role in infectious disease research, HIV research, as addressing the structural issues within the research enterprise that actually hold us back from achieving our public health goals, ending the HIV epidemic, addressing health disparities, because we live in a society that by design treats people differently. We live in a society that by design is violent to communities of color, that is, violent and discriminatory to LGBTQ plus people, to women, to people with uteruses. We're even at a moment now here in 2022 where bodily autonomy, which to me is one of the most basic fundamental human rights, is not a human right in the United States. We were just told that by the highest court in the land. We don't even have bodily autonomy anymore, the right to choose what we do with our own bodies, to make decisions about our own bodies. So I bring up this, sociological background because every system and every structure in our society has this legacy of racism, of misogyny, of anti-transgender antagonism. All of these systems of discrimination and oppression, they're built into every single structure in our society, our school system, our health system, and our research system as well. So I see my role in research as addressing those issues and correcting them, because if we continue on the status quo will just continue to perpetuate these injustices that we see in all of our structures. So, to kind of take it back to your previous question about this engagement process, honestly, I have like some trust issues when it comes to, correcting these injustices. When I see problems that are tied to justice related issues, I'm not always optimistic about the outcome, because when you look at every instance of a court case, for example, of police violence against Black people in our country, once again, the court upholds the status quo and fails to create meaningful change for communities of color, for Black individuals in our society. We're looking at our rights eroding in this current moment in our society. So I'm not always optimistic when I engage in issues, related to justice, that people will stop and listen and make meaningful change. And that's why I want to say how unique this situation is with this paper. I know it may seem like small. We're talking about, multi-syllabic words, phylogenetic analysis, and molecular HIV surveillance. And maybe there's only 77 people on this call. We don't have the entire United States listening to this conversation. But these issues are interrelated with all of the other social and structural and political factors that we're dealing with and we're reckoning with at this current moment in our society. So I think it's really important and profound that this research team, which in many ways represents one type of power structure that we have in our society, but this research team stopped and listened to community concerns and adjusted. And instead of publishing the original paper, recognized that there were harms involved in that and pivoted, changed direction, invited me and another author from the community to actually co-author this other paper to create change within the research enterprise. So I just wanted to note how powerful that is and how unique this situation is.
Yeah, absolutely. Thank you so much for that. And I think, we're not confused, right? That the communities that are most frequently implicated in these types of studies, first of all, in order for transmission to occur, you have to not be virally suppressed. So we're not confused about who that is in this country and about the structural inequities that make it that way, and about how those communities are policed and harmed and criminalized and increasingly vulnerable. And that, now we are in the midst of a moment where you can be criminalized both for seeking or obtaining an abortion and also potentially for breast or chest feeding your child. So we're really in a very interesting moment where I think these issues are very complicated, and it shows a lot of intention for researchers to consider, for this team of researchers to have considered at this moment in time, do the potential harms outweigh the potential benefits of this research? And it's a question that I think we have to keep answering and asking. There are a couple other questions, there are quite a few other questions in the chat, and I'm wondering if we can get to just a couple more, particularly the ones that are related to research. So one is from Alex McClelland. Could there be a way forward around developing renewed codes of ethics for researchers or ethical standards guidelines to outline ethical issues with the use of data for research garnered this way from health departments or other data sets where consent wasn't garnered for secondary use? Are there more discussions happening in the phylogenetic research world with other researchers about this? Can anyone speak to that?
I'm happy to start us off. I mean, I think sort of just off the cuff, like, I think we're in a moment where even beyond MHS, there's a lot of push from communities and from within the research world as we diversify who counts as a researcher. Many of us who have been on are being researched, right? Which really changes the conversation. There really is a big push around community engagement. So I think we're at a very important moment in terms of developing new codes of ethics, and whether that's happening or how it would happen, I don't know. It looks like Brian has popped something in the chat and may know more about that.
Yeah, so a couple years ago, Liza Dawson, who's currently with Walter Reed, she put together a team, including myself, that was tasked with developing recommendations for primarily clinical research. So kind of back to what I was referencing earlier with phylogenetic analysis that's taking place in the context of clinical trials, HIV clinical trials. So I shared the link there. I think it can be shared with everyone. Yeah, there it is. So this paper is really more for clinical researchers. There is a section in it that also deals with secondary uses of HIV sequences. But I think there needs to be probably a separate initiative looking more at these databases where HIV sequences derived from clinical care, from doctor's appointments, are accessed. You know, a lot of these are public repositories where really anybody can go in and access the sequences. So I think there needs to be some type of separate project that really deals with the ethics of using these type of databases and sequences derived from clinical care.
Thank you. Great. We're just trying to get through as many of these questions as we can in the Q&A. Keep them coming if you still have questions. Here's another one maybe that we could get to. Yes, would another type of phylogenetic study be more justified? For example, if there were not potential to stigmatize communities of color, but a clear public health takeaway, would you still have published? Or does the way the data was collected make all this type of research unethical? Love to hear perspectives on that.
I can try real quickly. I do think another type of phylogenetic study would be more justified. Like for example, you could do a population level screen for resistance mutations. Like we would use those sequences, and we could just screen over time the like increase or decrease of certain resistance mutations, and unlinked to any demographic variables at all. Just at a population level, are we seeing resistance increase or decrease? That would have public health relevance, but it wouldn't have the, I think, in my opinion, the direct potential for a stigmatization or other negative consequences. Would the rest of the panel agree with that or not?
Other thoughts? Okay, we can go to another question. There's also a question about, are there lessons learned for phylogenetic research of other pathogens for which the context of criminalization and stigma are different, such as COVID, that involve use of data collected from routine clinical specimens and data without consent? I think that's a pretty big question. I don't know if anyone wants to try to tackle that one, but certainly there is, the similar technology being utilized for tracing COVID, tracking COVID.
Yeah, I'll go ahead, Diana. You go first.
Go ahead first. Are you sure? Okay. I think there's two things that make molecular HIV surveillance particularly unique. The first is the criminalization. I think we really can't get around concerns around the use of MHS in public health or research without addressing the issue of criminalization. And the second is because HIV evolves at such a fast rate, faster than HIV transmission occurs, this means that you're able to really construct these tight transmission networks. And even though it's not possible to infer or prove direct transmission, I think it could be suggested or misinterpreted to prove direct transmission between two people whose data are being collected and used in this way without their consent. That is not necessarily true of other pathogens, although I do think there are some similar ethical concerns that should be considered.
Yeah, thank you. And I think another thing that's really critical to lift up here is that HIV is criminalized, and a lot of the routes of transmission of HIV are also criminalized. So, we talked earlier about the potential of about the way legislators and politicians are talking about same sex. We can talk about sex work. We can talk about substance use. So there are lots of vulnerabilities that are more specific to HIV and to communities that are disproportionately impacted by HIV, including the racialized disparities we talked about earlier. I think maybe one last question before we go to some final announcements and closing thoughts from Doug Rose. A strategy being used some research to collect data about how people feel about MHS. Now, this is something that we've seen, published in the literature, sometimes like attitudes of people living with HIV about participation in molecular HIV surveillance. This is also something that CDC has been using in their own presentations to, kind of show community attitudes towards molecular HIV surveillance. And Doug is sharing with us a particular example of this doctor who's showing an educational video about the science of MHS to people living with HIV and documenting their reactions without raising any of the potential ethical or legal concerns. Does anyone know anything about this? And could they say anything about it? Or have any comments to offer, reflections?
I can offer some reflections. I didn't know anything about this research, and I appreciate you, Doug, sharing this. I'm interested to look into this more. The first thing that comes to mind is it seems to me like there's some egregious ethical issues happening here, right? That folks are being exposed to something that we have heard from like many folks in the community is stigmatizing, right? The other thing I find myself thinking is that like wanting to know how people feel about MHS versus wanting to know what people think about MHS are potentially two very different things. And so I would want to know, like, what's the end goal? Like, why would it be important to understand the felt embodied response to this kind of investigation? I will say that as I was interviewing people for the qualitative study, again, different study, right? Qualitative study, asking people their perspectives, I early on recognized that what the responses that I was getting from the folks I was talking to seemed to me like they weren't fully understanding the legal and ethical implications. And so I started drawing out like potential ethical and legal issues, right, that might play out. I later learned that this is something that folks within the HIV community are suggesting not be done, particularly related to MHS. And why I'm sharing this is just to say that like, there is definitely a shift in how many people responded once many of these legal and ethical implications were unpacked a little bit, and people were able to tie some of these hypothetical possibilities that I was putting out there to things that they very likely could see happening in their community. I do think it's different though to ask somebody their perspective with the goal of thinking about messaging than simply to study the way people feel about something that we know is potentially very harmful. It's just a reflection. Curious what other folks on the panel think.
Panelists, feel free to chime in. It looks like we might go a few minutes over. Hang with us if you're good with that, because there's still, I think, a lot to say.
One thing I'll just add kind of briefly, and this can be kind of like a closing thought of mine as well, is CDC has made it abundantly clear that they're not going to stop the requirement for health departments to conduct cluster detection and response and molecular HIV surveillance activities anytime soon. Naina and I and many others were recently at a meeting where this was made very clear, and multiple presentations CDC is going around making right now very clearly indicate CDC will continue requiring this of health departments. So what I would say is, we can continue this philosophical debate about, should we be doing this? What are the ethics of doing this? But the reality is this is happening in real time. As we're speaking here, CDR and MHS activities are happening. So my call to health departments who are tasked with doing these activities would be to engage in community engagement. Lessons learned from community engagement is the title of this paper. If you're being required to do this work, it's not too late. Like, obviously, it would have been ideal to have gotten consent and done community engagement before engaging in these activities. But because this is our current reality, I would really encourage health departments to, contract with people living with HIV, people in the community, to help them conduct these community engagement activities and to take a harm reduction approach. Since this is not going anywhere anytime soon, find out how communities of people living with HIV would benefit, from participating, providing input into this process so that harm can be reduced as much as possible.
Thank you so much. And thank you for also sharing those closing comments, Brian. So I do want to highlight that there are a couple of sessions coming up at the International AIDS Conference in Montreal next week that specifically speak to this issue. For anyone who's going to be there, whether it's virtually or in person, we hope you will join us. Some of the folks from this panel will be in some of these sessions, and we think they'll be really powerful. I do want to invite other panelists also to share some closing thoughts with us before we transition out. And I apologize that we didn't get to all the questions, but this is an ongoing dialogue. We've been in dialogue as a community about this issue pretty robustly for about 4 years now, and that's not over. So if you'd like to stay engaged in this conversation, sign up at pwn-usa.org. We will continue to keep you informed. We will also try to address some of the other questions that didn't get addressed here in a follow-up email to anybody who is registered for this webinar, as well as sending out a recording. But for the panelists, what are your hopes in publishing this paper? How do you hope this will inform and influence research processes moving forward? And Brian, I think you kind of spoke to this already. Alic, if you would like to start us off.
Sure. I think generally speaking, I hope that this prompts reflection on the part of researchers and more deep engagement with the communities you're working with, whether that's communities of folks who are living with HIV where MHS is potentially implicated, or whether that's other communities. I think we're at a really pivotal moment in the research world where we need to really research needs to begin with the things that concern communities the most, right? What are the questions that communities want answered? And how do we deploy resources to answer those questions? And then also, I think this, from my perspective, is an example that just because one has begun a research project that's funded by the NIH doesn't mean that that all results need to be published. So thinking about what gets put out in the journals, I hope this stands as an example that it is possible to not publish or to speak more process oriented about how your research has changed as a result of the concerns that community has raised.
Thanks, Alic. I just want to echo what Alic and Brian have said, and that I hope researchers learn something from our experiences, and that one of the main things is that it's never too late in the research process to minimize the harmful impacts of your research and to do something different. When we paused our research, our manuscript was like ready to ship off to journals for publication. And so we are at the very, very end stages. And so you can also do that.
Huge. Josh?
Yeah, I have so many thoughts. This has been a really hard process for me the whole time, because I do believe in I'm not a clinician or a social worker or I'm just a scientist trained in phylogenetics who wanted to help with the HIV epidemic in the United States, and this was one way I could do it. And then to find out that what I was doing raised a lot of concerns, some very strong concerns from the community of people living with HIV, was hard and is hard still. It's hard for me to hear some of the linking of MHS to larger, or well, I'll say it first, larger issues of bodily autonomy in the Supreme Court. That's really hard for me to hear, even because I can compartmentalize this research and these questions and these methods because I believe in the goal. So it's hard for me to step outside and hear that, well, even though I can compartmentalize them, other people link them to much broader problems in society and in government. And I don't know what the end the outcome of this pause will be. I think it's a beautiful paper that Diana wrote. I hope people will read it, and people like me will at least pause and, as Brian suggests, it's not too late to engage with the community. It's not too late. It's been a great process. I've learned a lot, and everyone I've talked to has been so kind and generous with me. And so overall, I think it's really, I hope that, yeah, it's, I will probably continue to do research like this, but very differently, I hope. At minimum, I will try to push PHS, King County Public Health, to be more transparent with their use of this data. Like Alic has suggested, I think that's like a bare minimum that other public health localities should approach, is transparency. And then I will try to engage the community prior to publication. I'm not sure I can do anything about the informed consent or the criminalization aspects of this, which are very important, but at least to me feel beyond my control. But this is something we can do, and I really appreciate all of the co-authors. They've really helped me to learn a lot over this process. And I think this is, anyway, I could talk for a long time. We'll stop now.
Thank you so much. I think that was perfect. I think that really what you all have done is truly incredible, and is such an offering to the community, to the field, to the research ethics community as well, to really deeply consider how these issues intersect. And I'm so grateful to you all for making the time both to engage in this really thoughtful process and to come here and talk about it with the community in such a transparent and open way. And, I think the technology has technology and surveillance in so many forms can have a lot of utility and are never power neutral. And so I think this conversation has really in some ways highlighted the ways in which our positionality informs how we understand and interpret the potential harms of technology as well. And, there's for folks who are living at the intersection of multiple forms of structural violence, it's really hard to disconnect these things from each other because they're not actually disconnected in any kind of way. So yeah, there's so much appreciation to you all for your time, for this conversation, and let this conversation continue. Please sign up for updates with us, pwn-usa.org. We will continue to keep you informed about the latest and the greatest in conversations on molecular HIV surveillance. And thank you so much again to all of the authors here today and to all of you for joining us. We'll be in touch soon. Take good care, everyone.
Thank you. Thanks so much, Naina and PWN.
Thank you so much.